of MD Anderson's NCI-funded spore in ovarian cancer, and as a co-project leader of Project 3, Personalized Therapy for Women with Low-Grade Serous Carcinoma of the Ovary. Gershenson's expertise in the field expands far beyond MD Anderson, with leadership roles in numerous national and international organizations, including the NCI-sponsored cooperative group, NRG Oncology, chair of the Rare Tumor Committee, and a principal investigator of an international trial between the NRG and a research group in UK for women with a recurrent low-grade serous carcinoma of the ovary. Of all his accomplishments, though, Gershenson said he's most proud of ushering in the next generation of gynecologic oncologists to make a difference in the lives of patients. His talk today is on Unraveling Ovarian Cancer, New Treatment of Rare Subtypes.
Thank you very much. It's a pleasure to be here this morning, and I'd like to thank Runzi for inviting me to spend a few minutes discussing unraveling the heterogeneity of ovarian cancer, particularly epithelial ovarian cancer. This is just medical speak for the accumulation of information and data on the biology and the clinical behavior of ovarian cancer that allows us to make advances in the treatment of epithelial ovarian cancer. I have no disclosures relevant to this talk today. So you already heard from Dr. Diaz-Aristia about the various classifications of ovarian cancer. We're not going to talk about the first two sex-cord stromal tumors and malignant germ cell tumors, but instead we'll focus on the most common type of ovarian cancer, which is the epithelial ovarian cancer. And there are several subtypes of this, and we'll talk mainly on about four of them: high-grade serous carcinoma, low-grade serous carcinoma, clear cell carcinoma, and mucinous carcinoma. So the treatment of ovarian cancer fundamentally has not really changed much in the last several decades. It primarily consists of initial surgery, and for patients who have early stage disease, that would be removal of the ovary or ovaries with the fallopian tubes typically, as well as biopsies of many areas within the abdomen to rule out any spread of the cancer. But for patients who present with advanced stage ovarian cancer, and that's predominantly maybe 60 to 75% of women, the principle is maximal cytoreduction to reach a minimal residual disease. And the chemotherapy, really since the mid-1990s, has consisted of a platinum drug as well as a taxane drug, typically Taxol. So over the last several decades, women with ovarian cancer have been treated similarly, regardless of what subtype they have. But that's really changing. And just because we've always done it that way doesn't really mean that it's not incredibly stupid. So we've now entered, I think, an era with a new paradigm, and that's the fact that epithelial ovarian cancer is not one disease, but it's several distinct entities. And over the last decade, these advances have occurred because we understand a lot more about the clinical behavior of the various subtypes, and I'll talk a little bit about that. There have been new pathologic diagnostic criteria, but most importantly, we've learned a tremendous amount about the molecular biology and genetics of epithelial ovarian cancer. So if you think of it, prior to 2005, all of these cancers were treated the same, regardless of cell type. There were no prospective clinical trials that segregated women who had rare subtypes into selected treatments. In 2005, the NCI's Gynecologic Oncology Group established the Rare Tumor Committee, and at that point we began to develop new clinical trials with novel agents specifically for women who had some of these rare subtypes. And so it certainly is true that one size does not fit all. So while our President Trump is involved in extreme vetting, I think the medical community is involved in extreme splitting. So while we viewed ovarian cancer historically as one disease, it's now several diseases, and that splitting will continue as we move forward. It hasn't yet stopped. So we're going to talk about the most common type of epithelial ovarian cancer, high-grade serous type, and then 3 rare subtypes, just to give you a few examples of how advances are being made in this field. So let's talk about high-grade serous carcinoma, the most common subtype. It accounts for about 60% of all epithelial ovarian cancers. A few years ago, the National Cancer Institute sponsored a project, the Cancer Genome Project, that profiled molecularly about almost 500 high-grade serous carcinomas from across the country. And they were able to divide high-grade serous carcinoma into 4 subgroups. Now, we haven't really been able to take advantage of this information yet to treat each one of these women with each one of these subgroups of women differently, but I think that will evolve over time. So even when we're talking about splitting into subtypes, we're further splitting into more subgroups. You've already heard also that the fact that about 20% of high-grade serous carcinomas are associated with the BRCA mutation, so with the hereditary breast ovarian cancer syndrome, and another 50% may have a somatic mutation. A somatic mutation is simply a mutation of the tumor, but it's not a germline mutation. We also know that mutations of the BRCA genes result in increased frequency of gene rearrangements within the tumor. The PARP enzymes appear to play an essential role in the repair of single-strand DNA breaks within the tumor. And now we have PARP inhibitors. So PARP inhibitors lead to double-strand DNA breaks that cannot be accurately repaired in tumors with HRD, which is homologous recombination deficiency. And so this is kind of responsible for the fact that women who do have a BRCA1 or 2 mutation tend to have a better prognosis than women without that mutation. But PARP inhibitors have been one of the major advances over the last 5 years or so in the field of ovarian cancer therapy. So if we think of high-grade serous carcinoma and the possible genes or pathways that may be targets for some of these novel treatments, so first of all, the PARP inhibitors, there are now 2 PARP inhibitors, olaparib and rucaparib, that have been FDA approved for the treatment of ovarian cancer. Niraparib is a third that probably will be FDA approved this summer as well. So this has opened up a whole new landscape and options for treatment of women, particularly women who have a BRCA mutation, but also even other women who don't with ovarian cancer. The angiogenesis pathway is very prominent. So anti-angiogenesis drugs target the blood supply to the tumor cells rather than the tumor cells directly. There are a number of these drugs that are now available. Bevacizumab or Avastin, the brand name is Avastin, is active, certainly in ovarian cancer, and has been studied in multiple clinical trials. Dr. Diaz-Aristia mentioned the p53 gene, which is virtually mutated in every tumor, every high-grade serous ovarian cancer, and there are also a number of drugs that are being studied in clinical trials to target the p53 gene. And then about 30% of these high-grade serous carcinomas may have an aberration in what's called the PI3 kinase AKT-mTOR pathway, and there are a number of drugs that have been developed for targeting that pathway. So many more options than we had previously. So this is a CT scan of a couple patients who have high-grade serous carcinoma who were treated with PARP inhibitors. And by the way, PARP inhibitors are oral agents. So you see the first patient, number 20, you can see had this implant that's circled on the left, had 4 months of treatment with PARP inhibitor, and she had a very good partial response, not a complete response. Patient 41 on the bottom on the left, you can see that implant in her abdomen on the left side, And she experienced a complete response, complete melting away of the tumor with the PARP inhibitor. So these drugs can be very effective in treating women with high-grade serous carcinoma. This is just a listing of multiple clinical trials that have been conducted over the past several years with anti-angiogenic agents, again, most commonly Avastin or bevacizumab. And what these trials have learned and found is that the progression-free survival may be improved significantly for women in these clinical trials who received bevacizumab. Most of the trials did not show any improvement in overall survival, except the one on the bottom did show a slight improvement even in overall survival with the use of an anti-angiogenic agent. So now turning to the three rare subtypes and kind of thinking of them in comparison with the more common high-grade serous carcinoma, we know much less about these rare subtypes because they are so rare. Clinical trials are very difficult to conduct because there aren't that many patients, and so most of our information is derived from retrospective studies as well as post-hoc analysis of prior clinical trials. All three of these subtypes, low-grade serous, clear cell, and mucinous, share a common property, and that is relative resistance to conventional chemotherapy, platinum taxane chemotherapy, or other chemotherapy agents. So it's important that we search for new agents that may be more effective. So just to briefly discuss each one of these three rare subtypes. So this on the left, you see a listing of several phase 3 clinical trials that included hundreds of women with advanced ovarian cancer. And after these trials were completed, investigators compared those patients who had the rare subtype mucinous carcinoma with women who had the typical serous carcinoma. And what they found in virtually every trial was that the women who had mucinous carcinoma had a much worse outcome than women who had serous carcinoma. So again, underscoring the fact that we really need to have much better treatments. So these are some of the key pathways and potential targets for mucinous carcinoma. Again, the anti-angiogenic drugs such as bevacizumab and aflibercept and some others have shown activity, particularly in mucinous carcinomas. We also know that about 20% of mucinous carcinomas have amplification of HER2/neu, and so that's a target. That also occurs, for instance, in breast cancer. The MAP kinase pathway, particularly related to RAS mutations, that Dr. Diaz-Aristia also mentioned, they have aberrations in about 50% of mucinous carcinomas, so there are a number of drugs that are being studied for that. And then SARC may also be a target for future clinical trials. This was a clinical trial that was an international trial with our colleagues in the UK, specifically for women with advanced stage mucinous cancer of the ovary. Again, a very rare subtype, although when we started this trial, we didn't really realize how rare it was. And so patients were randomized to the conventional therapy, as you see on the left, Taxol and carboplatin, versus a new regimen, oxaliplatin capecitabine, which is a regimen that's used for instance, colorectal cancer. And then there was a secondary randomization to either bevacizumab or no bevacizumab. Unfortunately, because of the rarity of this subtype, we were not able to complete accrual to this trial and it had to close prematurely. So we really learned very little, unfortunately. But it did make us realize how rare, in fact, this subtype was. And I think now worldwide investigators are regrouping to determine how best we can move forward in studying this rare subtype. We've been a little bit more successful in the last two I'll briefly mention. So the first is clear cell carcinoma. So again, on the left, a number of clinical trials with hundreds of women with advanced ovarian cancer. And you can see that with the one exception, women who had clear cell carcinoma of the ovary fared much worse than women who had serous carcinoma. So again, underscoring the fact that treatments are pretty poor for this subtype. We know that there is a tumor suppressor gene called ARID1A that is mutated in about 50% of clear cell carcinomas of the ovary. And so that's definitely a potential target. In addition to ARID1A, we also know that anti-angiogenic agents, again, have very good activity in general in clear cell carcinoma. The PI3 kinase AKT mTOR pathway has abnormalities in about 40% of these tumors, as does the IL-6 STAT3 HIF pathway is also abnormal in about 50%. c-MET is another potential target because it's amplified in about 30% of clear cell carcinomas. There are a few others there, but again, importantly, the ARID1A mutations are of great interest right now, and there has been a new drug that's been developed that's going to go into clinical trials in the very near future for women specifically with clear cell carcinoma. And then finally, PD-1 and PD-L1. These are targets for checkpoint inhibitors, which are a type of immunotherapy. You're going to hear a lot more about this in a few minutes from Dr. Jazari, but PD-1 inhibitors or PD-L1 inhibitors may have very good activity in clear cell carcinoma of the ovary. So this is an example of a patient from a recent clinical trial that was published a couple of years ago. A 60-year-old woman who had recurrent clear cell carcinoma of the ovary. She was treated with one of these checkpoint inhibitors, nivolumab, and the 3 lines of previous conventional chemotherapy had already failed. And as you can see in the CT scans from the left to the right, that she had almost a complete response initially, and this lasted for well over a year. And on the right there, you can see her CA-125 values decreased dramatically during the treatment with nivolumab. So this is of great interest, and there are second-generation clinical trials with checkpoint inhibitors that are being developed. Another example is a combination of the standard or conventional chemotherapy with a drug that targets the PI3 kinase AKT mTOR pathway, temsirolimus. And this is a trial that's been completed now with 90 patients, and the results are currently being analyzed. And there are several other trials that I don't have time to mention, but I think we are making slow progress with clear cell carcinoma. And then finally, low-grade serous carcinoma. Historically, serous carcinoma was graded with 3 grades, grade 1, 2, and 3, well to poorly differentiated. In the 1990s, pathologists at MD Anderson began to look at this and think, well, it may be better to just have low-grade, high-grade, so a binary system rather than using 3 grades. And this study was published in 2004 and now has been accepted by the World Health Organization as the standard grading system for serous carcinoma, the most common type. Our group has a great interest in this particular subtype, and we've published a number of studies that show that borderline tumors may lie on a continuum with low-grade serous carcinoma, so the patients who have borderline tumors in rare cases may subsequently, even years later, develop low-grade serous carcinoma. And we've also published a number of studies in multiple clinical settings, again, that indicate that this particular subtype is not very sensitive to conventional chemotherapy. Interestingly, we've also found that low-grade serous carcinoma bears a striking resemblance to breast cancer, particularly estrogen receptor positive breast cancer. So at least 80% of low-grade serous carcinomas express the estrogen receptor. We've also found that young women, 35 years of age or less, who have low-grade serous carcinoma fare worse than older women. We also know that low-grade serous carcinoma seems to respond reasonably well to hormonal therapies. And again, these are hormonal therapies that are typically used for breast cancer treatments. And then finally, we've recently showed that for women who have primary treatment with surgery followed by chemotherapy, that if you then place them on a maintenance therapy with a hormone such as an aromatase inhibitor, that they will have a better outcome than women who just go on surveillance after they complete primary chemotherapy. And so there's a clinical trial that's currently in development to test that hypothesis. We know quite a bit about the molecular biology of low-grade serous carcinoma, and we know that on the right there that the MAP kinase pathways, so RAS, RAF, MEK, and ERK, are involved somehow in the pathogenesis of this rare subtype. So about 40% of low-grade serous carcinomas have a KRAS mutation, about 5% have a BRAF mutation, and drugs have already been developed and are in clinical trials to target these genes. In addition, we know that the insulin growth factor receptor 1 is overexpressed in low-grade serous carcinoma. That's another possible target. We also already know that the anti-angiogenic agents have special activity in this tumor as well. And then I've mentioned the estrogen receptor, which is a focus of several clinical trials under development. So just a couple of examples in closing. This is a phase 2 trial of 52 women across the United States who had recurrent low-grade serous carcinoma who underwent treatment with an oral MEK inhibitor, MEK inhibitor called selumetinib. And we found that 15% of women actually responded to this treatment, but another 65% of women had stable disease. And so there was about an 80% clinical benefit rate in this trial. This is one of the patients from the trial, again a CT scan on the left that shows a tumor in the right abdomen with the arrow. And as you can see, in a period of 4 months, this tumor decreased by 50% with treatment on selumetinib. There's now a second generation trial, which is a randomized trial of 250 patients who would be randomized to either a standard of care, which could include a chemotherapy drug or a hormonal agent, versus another MEK inhibitor called trametinib. If patients do randomize to the standard of care arm on the left, and they do develop progressive disease, they can cross over and still receive the experimental agent trametinib. And so far we've accrued almost 200 patients out of the 250 patients. This is an international trial, again, with our colleagues in the UK. The BRAF inhibitors also have been tested somewhat. Again, BRAF mutations occur in only about 5% of these low-grade serous carcinomas, but again, this is a patient who had a very good partial response for over a year with an oral BRAF inhibitor. And finally, this is a trial that's under development with a hormonal agent, letrozole. It's a randomized trial combining letrozole with a drug that's been now FDA approved for breast cancer, for ER-positive breast cancer, which inhibits CDK4 and 6, and it seems to enhance the activity of the hormonal agent. And so we're very interested in seeing if this does the same thing for women who have low-grade serous carcinoma. So in conclusion, one size does not fit all, and I think we are already in an era of personalized cancer therapy where we can profile the tumor, we can review the genes, and using that information select better therapies. But not only better therapies, it will also give us information about what treatments may not be effective in women whose tumors include certain mutations or who may experience very untoward side effects. And so I think we've got a lot of work to do. We're in the early phases of the personalized cancer therapy era, but I think we are making slow progress. Thank you very much for your attention.